Let's start our lecture today. Our first speaker today is Dr. Lo Wei-Ping. She is my colleague in Queen Elizabeth Hospital, and she graduated from the Chinese University of Hong Kong in 2005 and received nephrology training in our hospital. And she passed her exit examination in last year, and she also gave quite a number of presentations in international and also local nephrology meetings. And her topic today is the long-term preventing long-term dialysis complication. So Dr. Lo, please.
Good afternoon. I'm glad to have this opportunity to give this presentation today. This is the first session in the course. I'd like to give you some warm-up only. I will talk about preventing long-term complication of dialysis. The three parts: complication about the dialysis and those particularly related to peritoneal dialysis and hemodialysis. From the Hong Kong Renal Registry Report 2012, there are 1,115 new cases of end-stage renal patient entitled to renal replacement therapy, including peritoneal dialysis, hemodialysis, and renal transplantation. You can see that the number of patients receiving renal replacement therapy is increasing across years. For the peritoneal dialysis, there are 3,573 patients, consists of about 43.6% of all renal replacement therapy. This is due to the PD first policy in Hong Kong. This chart shows the distribution of different types of peritoneal dialysis. Hospital, satellite centers, home or private sections. It consists of about 26% of dialysis population. Most common mode of peritoneal dialysis is CAPD. For the CCPD, APD, or NRPD can take place with a machine. Hemodialysis can take place in the hospital as chronic hemodialysis or acute hemodialysis, or it can take place at home. It can be operated at different duration of frequency. It can also be filtration and hemodialysis, which is called hemodialysis filtration. Cardiovascular disease, problem about the GI tract or anemia. Mastitis fibrosa, which is result from high profile hormone. It results in increased inflammation and disruption of the bone and increased myelofibrosis. It will result in high chance of fracture. Patient usually present as bone or joint discomfort, acute joint inflammation, pain or stiffness. On the other hand, if the profile hormone is too low, it will result in adipocyte bone, which is result from decreased osteoblast or osteoblast number, so that the bone formation will be low or absent. The chance of fracture is also higher. And also the serum calcium level will be increased because there is impaired ability of the bone to buffer the serum calcium, and in turn result in vascular calcification. Osteomalacia, which is a state of low bone turnover. There is presence of unmineralized osteoid. You can see that the density of bone is much lower here. The holes are much bigger than the normal one. In order to prevent this bone disease, the peripheral hormone level should be kept in target range, which is about 2 to 3 times upper limit of the general population. Calcium supplements should be given to reach the target level of serum calcium. Phosphorus should be controlled, so the diet should be consist of a low phosphorus diet, and also dialysis can help to reduce the phosphorus level. Phosphorus binder is also help. Another problem is calcified uremic arteriopathy. It can present as lipido radiculitis, present as painful red nodules, or which can progress to ulcerative and necrotic lesions. The urea can damage intravascular smooth muscle cells and increase in ectopic mineralization. The blood vessels may become mineralized and result in arteriolar calcification, vascular occlusion, and tissue ischemia. We can see that actually these are two pictures showing the presentation of severe calcified uremic arteriolopathy. Another problem is dyslipidemia. Too high level or too low level of cholesterol can increase the risk. Hypertriglyceridemia is usually related to the deficiency of lipoprotein lipase or hepatic lipase. Lipid problem can be prevented by some general measures such as dietary and lifestyle modification, avoid alcohol use, doing regular exercise, and some medication such as statin, bile acid suppression, and nicotinic etc. Another cardiovascular problem is left ventricular hypertrophy. The first type is concentric left ventricular hypertrophy, which is usually related to hypertension, blood vessel stiffness, and aortic valve stenosis. Another form is eccentric one, which is usually related to anemia and fluid overload. In order to prevent these problems, modification of the risk factors such as anemia or hypertension is important. The fluid volume should be keep in balance and have strict fluid restriction. Other medications such as ACEI, ARB can help the regression of left ventricular hypertrophy. The disorder of mineral metabolism can also be related to the left ventricular hypertrophy because their impact on the myocardium. So the calcium, phosphorus, PTH, and vitamin D levels should have good control. Anemia should be corrected. Ischemic heart disease is also common. Myocardial infarction is the common presentation for those patients receiving dialysis. The mortality can be up to 50% in 1 year. Is this related to the atherosclerosis or arteriosclerosis? So medications such as aspirin, beta blocker, ACEI can help to reduce the chance of ischemic heart disease. Angina is also common during dialysis. Oxygen can help to reduce the symptom. Hypertension should also be avoided during hemodialysis. If the patient had hypertension, elevation of lower limb and saline infusion can help. Other treatment modalities include TNG, decrease the blood flow rate and stop ultrafiltration during dialysis. If the blood pressure can tolerate, pre-dialysis administration of beta blocker or oral nitrates can help. Heart failure is another problem. Patients usually present with volume overload, pulmonary edema, or dyspnea. They can predispose to diastolic dysfunction and valvular disease. So actually, general measures are important to prevent cardiovascular problems such as restriction of sodium intake. The balance between pulmonary edema and symptomatic hypertension should be paid very attention. And also other medications such as aspirin, beta blocker, ACEI, or ARB can help to protect the cardiovascular system. Arrhythmia is another heart problem, especially for patients with left ventricular hypertrophy, triple enlargement, valve abnormal, ischemic heart disease, or electrolyte disturbance. So that the electrolyte balance is very important, particularly for the potassium. Other medications such as digoxin, beta blocker, hydropyridine calcium channel blocker can help. For the gastrointestinal tract problem, patients usually present with anorexia, nausea, vomiting, dyspepsia, constipation, diarrhea, or hiccups. For dyspepsia, it can be related to hepatic ulcer, gastroesophageal reflux, gastritis, uveitis. It can be relieved by some medications such as H2 blocker, PPI, or antioxidant. Constipation is quite common in renal patients because patients are usually afraid to take a lot of water. So it can be prevented by high fiber food or some medications laxative. upper GI bleed can be prevented by avoid some medications such as NSAID or aspirin, avoid smoking, use some medications such as true-blocker, PPI, or anti-acid. If there is present H. pylori infection, it should be treated. Gastric retention is another problem. It can be related to the autonomic neuropathy. Prokinetic agents can be used to stimulate the movement of the GI tract. Another problem is anemia. It related to renal failure because it results from insufficient production of the EPO. Of course, other problems need to be taken off, such as loss from the breathing, dialysis, infection, inflammation, or inadequate dialysis, or related to medication ACEI, pure red cell and calcium extraction. It can be treated by blood transfusion, iron supplement, or EPO injection. All ions has some side effects, such as constipation, dyspepsia, bloating, or diarrhea. Some patients can tolerate them well, but it is more convenient for patients on peritoneal dialysis. It can in different preparation, but they should be taken on empty stomach to optimize the efficacy. And it should be separated from some medications such as phosphorus bounder, anti-acid, H2-blocker, or PPI, which may inhibit the absorption of all iron supplement. Side effect of constipation can be prevented by using stool softener or laxative. Another form is intravenous iron. It has superior availability and efficacy than the oral one. But it has some side effects such as anaphylaxis, presented as hypotension, dyspnea, or it can increase the risk of infection or oxidation. Injection of EPO can help to reduce the frequency of blood transfusion. There are different forms of EPO available in the market, such as erythropoietin, diabetic or serum. The hemoglobin level should be monitored after the start of erythropoietin stimulating agents. The target level is around 10 to 11 grams per decimeter, and the iron deficiency should be avoided. But of course, erythropoietin stimulating agents have some side effects, such as hypertension. And also, the injection should be avoided if the patient presents with hypertension, say systolic blood pressure greater than 160 and diastolic blood pressure greater than 90. Less common side effects include seizure, ground clotting, or difficulty in phosphate control. So we'll come to the complication associated with peritoneal dialysis. I divided it into 4 aspects. For the infection, exercise infection is also quite common. Patient usually present with glutinous discharge, redness, pain, skin induration, fever, or some discharge. The major risk factor is the staphylococcus leishman carriage. And some patients may have difficulty in attaching in the dialysis solution bag, such as those with obesity or some patients with some musculoskeletal problem. They may stress on the catheter, which can result in some tearing of the catheter. For the ISPD, they recommend the antibiotic prophylaxis, such as gentamicin cream, which can reduce gram-positive and gram-negative infection. Butyl cream, which can reduce gram-positive infection. For those Staphylococcus aureus carrier, and the miracle intralatally should be applied. Other exercise carrying, including washing and dry hands, inspect the tank of catheter, exercise frequently, and also taking shower instead of bath, and cleansing the exercise carefully, which can help to reduce the chance of exercise infection. And also the cleansing agents should be between the containers should not be transferred to avoid cross contamination. And tank-off catheter should be tapped and immobilized after cleansing, and also apply the dressing over the tank-off catheter. Another infection is CAPD peritonitis. Patients usually present as turbid fluid, abdominal pain, or fever. In order to reduce the infection, the exchange procedure should be performed very carefully in a clean area, and they should wash the hand or wear sterile gloves in order to decrease the transfer of bacteria. Fluid overload, of course, very common. It can present as hypertension, increased weight, and also edema. It can be related to inappropriate prescription, poor compliance, loss of residual renal function, mechanical problem, poor blood sugar control, or peritoneal membrane dysfunction. In order to reduce fluid overload, low short diet should be applied, and also for the blood sugar level should be kept in good control. And also the residual renal function is very important. It can be preserved by some medications such as ACI, ARB, or diuretic. With residual urine output, those patients should also avoid levotoxic medications such as enzyme. The peritoneal membrane function can be preserved by reduced peritonitis and also avoid high glucose concentration peritoneal dialysis food. The simple peritoneal sclerosis or sclerosing peritonitis, which can result in inadequate dialysis. Diabetic mellitus, which is a common metabolic disease, because the glucose is used as the osmotic agent in the dialysis, it will result in glucose absorption and hyperinsulinemia, which will in turn result in atherosclerosis, hyperglycemia, or hypertriglyceridemia. So the salt and water management should be very careful. And also, non-glucose-based solution can also help to reduce the diabetes mellitus or has better DM control, such as icodectrin. Another problem, of course, the lipid problem, which I mentioned before. They usually have high total cholesterol, LDL, and high triglyceride. HDL is usually low. Actually, this problem can be prevented by some general measures such as diet, exercise, or medication such as statin. Protein loss is another problem, which is quite common because about 0.5 gram per liter of dialysis drainage can result in protein loss. And the main component is albumin. And the loss is also increased during the period of infection, such as peritonitis. So high protein diet is suggested. For the mechanical problem, hernia is quite common. It is also increased risk for those patients with recent abdominal surgery, obesity, multiple patterns, which perform isometric exercise, etc. So for those with significant abdominal wall hernias, it may be better prepared before operate peritoneal dialysis. And also avoid large dialysis volume for umbilical hernia, and also avoid high intra-abdominal pressure. But sometimes it occurs after peritoneal dialysis. So in order to prevent it occur again, surgical repair can help. And also need to observe for any recurrence. Use abdominal binder or low volume dialysis in supine position can help. Sometimes CCPD with small gel can also reduce intra-abdominal pressure. Another problem is abdominal leakage, which can present as weight gain, decreased efferent volume. The abdomen protrudes without generalized edema, but it usually occurred after the commencement of the peritoneal dialysis. So the peritoneal dialysis should be stopped for a short while if possible. Sometimes remove or reinsert catheter is late, or surgical repair can be required. So some measures can help to reduce it occur again. We use low volume dialysis and also reduce deficit that can increase intra-abdominal pressure. genital edema. It usually occurs after start of peritoneal dialysis, so PD should be stopped if possible. Bed rest and scrotal elevation can reduce the edema, and also start the PD with low volume or supine position. For severe cases, surgical repair or replacement of the catheter is needed. If the defect is in the diaphragm, the fluid will drain into the chest cavity and result in hydrofluorus. Through drainage, repair of the defect in the diaphragm, prosthesis, or use surgical application can reduce the chance of recurrence of hydrofluorus. So after talking about the peritoneal dialysis, then we are going to talk about the complication of hemodialysis. These are the common complications associated with hemodialysis. Hypotension is more common in elderly and female. For those with too much fluid removal or rapid reduction in plasma osmolarity, or the fluid removed very quickly, or it can be related to autonomic neuropathy or poor cardiac reserve. So it is important to assess the dry weight accurately, although it's not easy. Nowadays, there are some machines to help us to assess the dry weight, such as VCM machine. And also the ultrafiltration, if it's more constant, it will also reduce the risk of hypertension. Sometimes some measures can be performed during the hemodialysis, such as increase the dialysis sodium concentration, use bicarbonate dialysis buffer, or temperature control can help to reduce the risk of hypotension. Medication such as middle-green alpha agonist, which was shown to have limited intradialytic hypertension in some studies, avoidable during hemodialysis, or a trial of serotonin, which can also reduce the risk of hypotension. Gramine is also common during hemodialysis. If there was too much fluid removal or at a very high rate, tissue hypoxia, or the peripheral hormone level was too low, or it can be related to some electrolyte disturbance such as sodium or magnesium. So hypotension during dialysis should be prevented, and also sometimes use high concentration of sodium in dialysis can also reduce gramine. Administration of quinine can prevent prolonged involuntary muscle contraction, can also reduce gramine. Another problem is metabolic problem. Beta 2 microglobulin amyloidosis is common. Patients usually present as shoulder pain, carpal tunnel syndrome, or sometimes contraction. They are lightering of the class 1 major HLA. It is killed exclusively by the kidney, so the level will be increased in patients with renal failure. This is also related to the residual renal function and duration of dialysis. Carpal tunnel syndrome is very common presentation in this problem, especially for those on long-term hemodialysis and for long term. Spinning can relieve the symptom. Steroid can give more permanent relief, but sometimes require surgical release, which is more effective. It can be also reduced by use high flux membrane during hemodialysis, use ultrapure dialysis or hemodynamic filtration. Of course, renal transplantation in early stage can also reduce this problem. Nutrition also is always a problem in renal patients because their food restrict in high salt, phosphorus, and potassium. And their food should include high proteins, which can provide essential amino acids. HNAS, of course, very common, which is related to high phosphorus level. So diet restriction or phosphoramide can help. If it is related to dry skin, keep moisture can help to reduce the symptom. Acids also result in a lot of complications. Infection, because they have access related to the blood, which can result in septicemia or infective endocarditis. The risk of catheter actually is higher than AVG, and which in turn greater than AVF. So in the chemical infection disease published in 2011, it suggests use 2% of Listerine wash for the daily skin cleansing, which can reduce catheter-related bloodstream infection. Use antiseptic ointment at the end of each section of hemodialysis. And also prophylactic antibiotic lock solution for those with history of multiple catheter-related bloodstream infection. Another problem is aneurysm. It is resulted from repeated puncture of needle. So the needle puncture site should be rotated every time, or use buttonhole technique. And also we should avoid insert needle into the area of aneurysm. Another problem is stenosis, which is result from narrowing of the blood vessel that slows the flow of blood. Usually it presents as swelling of the access lane, and also the venous pressure will increase during hemodialysis. It will result in decrease in adequacy of dialysis. Sometimes angioplasty is required to treat this problem. Still syndrome because of hypotoxicity tissue. The patient usually presents pain, tingling, cold feeling, or decreased feeling in the access lane. If still syndrome occurs, it can be treated by giving hand warm, change the position of arm, or surgery. Thrombosis is also common. Some common causes including the blood clot, low blood pressure, dehydration, or there is too much pressure on the access lane, repeat cannulation. It will present as reduced flow and fluid, and also the poor blood flow through the access. And also the prescribed blood flow rate cannot be reached, and there was suddenly swelling of the access arm, or the venous pressure is very high during hemodialysis. It can be reduced by preventing use that arm for blood taking or pressure checking, and also check for the flow and fluid every day. Do not sleep on that arm. Do not wear tight-fitting clothes, and also do not carry object over that arm, and avoid IV access and also IV injection on that arm, and do not wear watch if the fistula was done on that lower arm. Sometimes high output cardiac failure are pleasant and present as rapid pulse, SOP, or swelling of that knee, which is precipitated by anemia or heart disease. So anemia should be treated, and also the fluid gap between dialysis should be maintained, and also use longer or more frequent dialysis can help. Sometimes surgery to reduce blood flow through the access, especially for those already receiving transplantation. So, in summary, today I give you some general idea of the complication related to dialysis, and also some preventive methods are highlighted, and also briefly introduce some management for the complication of dialysis. Thank you.